jump right in. Welcome. This is day one of the Trauma Improvement Sprint. I want to start with our acknowledgement and disclaimer. So the Emergency Medical Services for Children Innovation and Improvement Center is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services as part of the following award, totaling $3 million with 0% finance from non-governmental sources. The contents are those of the author and do not necessarily represent the official views of nor an endorsement by HRSA HHS for the U.S. government. For more information, please visit HRSA.gov. The planners and presenters of this course have no conflicts of interest to disclose, and the session is being recorded. So a recording of each session today will be posted to the Trauma Improvement website here. So just a quick kind of a few miscellaneous items. Whoops, it's going fast. So you are muted and in listen only mode. So please use the chat and Q&A box for questions or comments. We will have a discussion hour at the end of each day. It's a different Zoom link because it's a Zoom meeting, not a Zoom webinar. If that difference matters to you. And that way you will be able to come off mute, you'll be able to have video, and we can have a more interactive discussion the last hour of each day. So if you go to the agenda, you'll be able to download that Zoom link later today. As I mentioned, the sessions are being recorded. They'll be posted to the website along with the slides from today. We'll make those available to you all. Probably by the end of tomorrow, those should all be available on the website. If you have any questions, you can email us at collaboratives@emscimprovement.center. Continuing education credit, you can see our learning objectives here, and to claim you must attend the live session to be eligible for credit. You're eligible for 8 hours. A post-session evaluation will be sent to you at the close of the session today and tomorrow. And if you have any questions, so you must complete that evaluation, I'm sorry, and in order to get your credit, give us a few weeks to get that to you, as there's quite a few of you. And then once again, if you have any questions, please email us at collaboratives@emscimprovement.center. So today we will be using a plugin called Poll Everywhere to really ask you a few questions and to engage you a little bit more. So there's about 3 different ways you can access Poll Everywhere. You can scan this QR code and it should take you to download the app, or to go to pollev.com/trauma-sprint. In the mobile app, you can enter trauma sprint to engage. And you also can text your answers to trauma sprint to 22333 to engage in the questions. So we're going to do a couple trial ones to help you get used to the Poll Everywhere app and download it. So I'm going to give you just kind of a quick minute to get there. I'm going to leave this up for a second. Like I said, scan this QR code, put this link into your browser. And yes, we will put, I see a couple of comments in the chat about the link to the slides. I'll put that in the chat right now real quick for y'all. Also gonna put, oops, let me go over here so you guys can get the Poll Everywhere downloaded. This is the link to today's agenda. The slides are not posted yet, but they will be, like I said, by the end of tomorrow. But here, I'll put the link there in the chat while everyone is getting to the Poll Everywhere. Okay, so hopefully you've at least gotten there to some extent. We're gonna do some quick, okay, why isn't it launching? There it goes. Okay, so first question. Oh, and I already see some of you are engaging. Perfect. So which of Snow White's 7 dwarfs best describes you? I like that Happy is taking the lead. That's fantastic. Seems like we have a few that are getting the hang of it. That's it. Okay, I'm gonna give y'all maybe about another minute to play with this. Amy, I can't get my pulled over on my phone. If you open your browser on your phone and just go to polyev.com/trauma sprint, that's worked well for me too. If you can't get the app to work, is that maybe what you're talking about, Amy?
Texting works really well too.
Yes, texting works well too. Oh, you did that. Okay. Okay, seems like if you have this down, I'm going to go to the next one, which is another question just to give you some time to play with this. And that is, where are you joining us from today? Feel where you are in the middle of the ocean. I like that. Maybe you're on an island. Nice. I'm seeing some in the chat. Far away is Poland. That's very neat. Welcome. Wyoming. It's very cool. Lots of people from all over the world. Maybe, or maybe the app's not working out. Okay, so I think you guys have the hang of it. This is really just to make sure you can get into polyev.com and /trauma sprint. Yes, I can imagine you can't find Hawaii. It's a little bit small on there, but so we'll be using this throughout the day to ask you a few questions, engage you. So we'll warn you before each session on how to get back to here, but I just wanted to give you kind of a heads up. So let's jump in. So talk a little bit today about the mission of the Trauma Improvement Sprint. Why are we here? What do we hope to accomplish? And so that really is to define pediatric readiness and really help you identify priority areas for improvement. A major part of that will be describing the role of the PEC, or the Pediatric Emergency Care Coordinator, which is really key to driving pediatric readiness, and why we really turn this the PEC Workforce Development Collaborative Trauma Improvement Sprint. Talk a little bit more about kind of how we got here. But our goal is to help you understand how to implement pediatric readiness efforts within your trauma center, learn about best practices, and network and identify go-to colleagues for support and collaboration. Okay, so over the course of the next 2 days, 2 half days, today and next Wednesday, we'll be spending about an hour on each of these 7 pediatric readiness areas of focus. So we'll cover 3 of them today and 4 next week. We'll start each hour with sort of a broad overview of each focus area. We'll talk about why this focus area is important, how it contributes to pediatric readiness, and what are the key considerations to think about. And then we will have someone who's done significant work in this area come talk about their work and how they've really driven improvement in this area. So a quick snapshot look at the slides, the agenda for today. Day 1, welcome from me. I don't think I introduced myself quite yet. I'm Meredith Rodriguez. I'm a senior project manager with the EIC. And then we will kick it off with Dr. Erin Jensen, who will talk about pediatric readiness and trauma systems. And then move through 3 of our focus areas, which will be the role of the PEC. And we have a fantastic PEC, or pediatric liaison nurse, Aspen, who will talk about her role and what she does. We'll highlight care team competencies, and Dr. Mark Auerbach will come talk about simulation and how you can leverage SIM. And then we will close the day with equipment, supplies, and medication. Dr. Jason Krellin will talk about some work he's done with improving equipment, supplies, and medication in his area. And then I will come back for a summary, quick summary, and then we can move to this open discussion hour. Day 2 looks about the same. Quick welcome from me, and then we will touch on policies and procedures with the wonderful Sally Snow. And then patient safety and family-centered care. We have Karen Groenweg. She's a child life specialist from Canada. And then we'll take a quick break for lunch, talk about communication and collaboration across systems of care with Lisa Nichols. And then you'll hear in the last hour from me about quality improvement. So it's kind of a snapshot of what those days will look like in the 7 pediatric readiness areas of focus. But I wanted to take a step back here and talk about who we are and how did we get here? Where did these 7 focus areas come from? And really how do we determine what equipment, supplies, and medication, or what policies and procedures you should have. And so a quick introduction to us. The Emergency Medical Services for Children, EMSC federal program, is administered by the Health Resources and Services Administration within the Department of Health and Human Services. We've been around for quite some time. We were authorized by Congress in 1984. And our focus is really on enhancing pediatric capabilities of existing EMS systems across the continuum of care. So from the emergency response, pre-hospital care, hospital care, through interfacility transfer to a higher level of care, rehab, and then injury prevention and working with our families and patient networks. So the EMS for Children federal program consists of several sub-programs, of which we are one of them, the EMSC Innovation and Improvement Center. We also have a sister center, the National EMSC Data Analysis and Resource Center, or NEDARC. We have more of a research arm, which is the Pediatric Emergency Care Applied Research Network, or PECARN. And then every state and territory has a local EMSC program, and these are called our state partnership programs. And you can see an example of several of the ones that we have up here. But as the EIC, or the EMS for Children Innovation and Improvement Center, our mission is to accelerate improvements in the quality of care and outcomes for children who are in need of emergency care. And we do this by using a foundation of quality improvement methodology and to really link resources, efforts, and entities to decrease child mortality and morbidity due to illness and injury. We do this in partnership with several professional organizations, including the National Association of State EMS Officials, or NASEMSO, the American College of Emergency Physicians, ACEP, American Academy of Pediatrics, AAP, ENA, Emergency Nurses Association, as well as the American College of Surgeons Committee on Trauma. So really the hallmark of the work that we do could be considered the National Pediatric Readiness Project. And the NPRP is this multi-phase quality improvement initiative that ensures that all US emergency departments have the essential guidelines and resources in place to provide effective emergency care to children. And the foundation for this project really began over 20 years ago now with the 2000 IOM report, now the National Academy, that detailed what many healthcare providers and patients already knew. And that is that, between 44 and 98,000 patients die each year in US hospitals due to preventable medical errors. And an even greater numbers suffer morbidity related to medical error. And the total indirect cost of medical errors that result in patient harm was estimated to lie between $15 and $30 billion annually. And this was over 20 years ago. So quickly following up on that, looking specifically at EMS systems, the Institute of Medicine commissioned a study of the US emergency care system in 2004. The IOM panel released its 3-part report, The Future of Emergency Care, in 2006. At a breaking point was the first of this 3-part report, which addressed hospital-based emergency care. And this report noted that the existing public safety systems are frequently overtaxed, and EMS and trauma systems are underfunded, and that hospital-based emergency departments are increasingly and dangerously overcrowded, and that pediatric capabilities of our emergency and disaster care systems is uncertain. And to go into this slightly further, the Emergency Care for Children Growing Pains report, the 3rd report within this Future of Emergency Care series of reports, detailed really what our EMS, the state of EMS care for children looked like in 2006. And in particular, it called for EDs and EMS agencies to appoint a pediatric emergency care coordinator, or a PEC. And we're going to dive into this role a little bit more in the next hour or so. But really, this PEC really ensures that the care team has the skills and knowledge to care for pediatric patients. They oversee pediatric QI initiatives, ensuring the availability of pediatric medications and equipment, and work to promote pediatric protocols and procedures. The one thing that was really important out of this report, out of the growing pains, was that more training and guidelines was really not sufficient, that we really needed to work with appointing a person who could actively work in promoting high quality pediatric care in every ED across America. So in 2009, kind of based on the IOM reports, the MSC program, members from the MSC program, together with the AAP and ACEP, published a joint policy statement guidelines for the care of children in the emergency department. This guideline policy statement was endorsed by 22 national organizations and describes the organizational principles to guide and define the pediatric healthcare system and improve the health of all children. These policy statements are considered sort of the national pediatric readiness standards, and delineates the recommended resources necessary to prepare EDs to care for pediatric patients. So quickly following the release of the 2009 Joint Policy Statement, the National Pediatric Readiness Project developed and released a National Pediatric Readiness Assessment. And what this is a comprehensive web-based assessment at that time in 2013 of over 4,000, which is 82% of US emergency departments. And so each department that took the assessment received a weighted pediatric readiness score on a scale of 0 to 100 based on compliance with the guidelines. Participants are also provided with a detailed gap report to target efforts for improvement in pediatric readiness. And then the National Pediatric Readiness Project has developed an accompanying checklist and toolkit to support improvement in this area. So a quick breakdown of what the scores look like across the nation, stratified by annual pediatric volume, demonstrated, maybe unsurprisingly, that the hospitals with higher pediatric volumes have a higher weighted pediatric readiness score. That's what that WPRS stands for in the corner. But was even more intriguing was that hospitals that had a nurse PEC, a physician PEC, or both had significantly higher weighted pediatric readiness scores, regardless of pediatric volume. And to take this a step further, Stephanie Ames and colleagues recently demonstrated that a higher pediatric readiness score, or those with the highest quartile, have up to a 4-fold lower mortality rate in pediatric patients. So to quickly bring us up to speed to where we are today, the 2009 Joint Policy Statement was revised in 2018 to include new evidence and best practices, and it's termed Pediatric Readiness in the Emergency Department. And similarly, in 2021, so August of last year is when it officially closed, we released another iteration of the National Pediatric Readiness Assessment, which was based on the 2018 Joint Policy Statement. We had about a 71% response rate to this assessment. 71% of the US emergency departments responded, even at the height of COVID, which was really a big win, we would say. So we'll go over this several times, but if you're interested in finding your score, your ED nurse manager should have this information. You can also contact your state and territory EMSC program manager. You can find their information on our website here. Your program manager will have to, your state or territory program manager will have to get permission from your, whoever took the assessment to release the results to you, but it's a pretty straightforward process. You can also visit pedsready.org to learn more about this assessment. And there's even a paper version on the website right now that you can download, take, and score yourself. So that's kind of a quick overview of pediatric readiness and the National Pediatric Readiness Project. But why should this matter to trauma systems? How does pediatric readiness relate to trauma systems? And with that, I'm going to turn it over to Dr. Aaron Jensen. He is the co-lead for our trauma domain here at the EIC. He's also an associate professor of surgery and associate director of the Pediatric Surgery Fellowship at UCSF, and associate trauma medical director at UCF and Children's Hospital in Oakland. So with that, I will turn it over to you, Dr. Jensen. Let me give you control of the screen real quick.
Thanks, Meredith. Good morning, everybody. Welcome to our trauma improvement sprint. 375 people on I'm seeing today. I think that's amazing. Happy to see everybody here with us today. I'm going to be very brief, but hopefully convince everybody that pediatric readiness does matter in your center. And just to be clear, today's webinar and next week is not designed just for pediatric trauma centers. This is for adult trauma centers, and this is for all centers that might take care of children within the context of our trauma system. And I think that's important because, I work at a level 1 freestanding pediatric trauma center, but most of my severely injured patients that I take care of have previously been resuscitated at another center and transferred to me for definitive care. And I think that's not just in my center. It actually is the case at many centers, and I'll show why that is. But pediatric readiness at all receiving centers, particularly adult level 1s, level 2s, and level 3s that don't regularly take care of kids, is exceedingly important. So hopefully I can make that case. And I'm going to start out, hopefully if I can, there we go, by just talking about 2 cases. These are real cases that I took care of. I've changed some of the details for anonymity's sake, but they really are emblematic of the importance of that initial receiving center. We'll talk about one case that is really emblematic of how it should be. Optimal care, optimal outcomes, and we'll show you a kid that really got truly exceptional care as a result of a collaboration between an initial receiving adult trauma center and a pediatric trauma center, and then one that has lots of opportunity for improvement. The system worked, but you'll see that we could have done better. So let's actually start out with that one. So, and some of you may have heard this case before, but I think it's really illustrative of the role of the initial receiving center. This is a 4-year-old who's a really small 4-year-old, even though his stated age is 4, he's 12 kilos. He's run over by a bus outside of your trauma center, and your trauma center happens to not be a pediatric trauma center. It's an adult-only trauma center. Whether that's a 1, 2, or 3 doesn't really matter, but you are not a center that is used to taking care of a child. And the child shows up in your ER because literally the bus ran over him outside on the street, and it was across the parking lot to your ED and your trauma center. So they brought you this child with a GCS of 6, who's profoundly tachycardic. You can't get a blood pressure, and his stats 68%. So critically injured child. You recognize that he's going to need some blood and he's going to need to be intubated. And he gets intubated with a 5.0 ET tube because you did some math. And if you do the math, you calculate that a kid who's 4 should get a 5.0 ET tube. You put a 5.0 cuffed tube in him, and that math is for an uncuffed tube. You're supposed to downsize by 1/2. But honestly, he's so small, he probably should have got a 4.0 cuff tube if you would have measured him by the Groslow tape or some other length-based assessment. So he gets a really large endotracheal tube put in, which is good. He needed an endotracheal tube. So this trauma center did save his life by securing an airway. He then gets transfused, and the adult massive transfusion protocol is activated. He gets a unit of blood, which is 300 cc's, and in a 12-kilo kid, this is 25 cc's per kilo, which would be the equivalent of giving an adult human 5 units of blood. So 1 unit, a whole adult unit in a 12-kilo kid should increase their hemoglobin by 5 grams. So this is a lot of blood, but it's perceived as, he got 1 unit of blood. He's still hypotensive despite 1 unit of blood, so he gets another unit of blood and responds. And because he's a responder to 2 units of blood, and which really is the equivalent of about 10 units given to an adult, he goes off to CT scan. Here's his CT scan. I put this up for illustration. This is his stomach, which is full of whatever he ate for lunch. This is not his stomach. This is his spleen, which is pulverized and has a lot of arterial extravasation. And soon after this CT scan, and you can see all of his injuries. He's got numerous fractures: grade 5 spleen, grade 5 liver, pelvic fracture, femur fracture. His ISS is 50. This is a critically injured child. And soon after this CT scan, he becomes unstable again when he comes back to the ED. And he's just too unstable to transport to a pediatric trauma center for definitive care. So he undergoes laparotomy at the adult trauma center with a splenectomy and packing of his abdomen. And he's transferred to a pediatric trauma center with an open abdomen. Intraoperatively, the trauma center followed their adult massive transfusion protocol to the T. So their protocol calls for 4 units of reds, followed by 1 to 1 to 1 after that. So he did get 4 units of reds total, and then got 1 unit of FFP and 1 unit of platelets. You can see here, it doesn't sound like a lot. I mean, it's a lot of blood for an adult, but it's not tons. But if you convert this into cc's per kilo for a 12-kilo child, you got 150 cc's per kilo, which is really about 2 blood volumes for a kid this size at a ratio of 7 to 1 to 1. So this is a super massive transfusion in a very small kid. And the result of that super massive transfusion, you can see his lungs really took a hit from that. He probably had some transfusion-associated lung injury, definitely had volume overload. He was very cold when he got to the pediatric trauma center. He was quite tachycardic, still hypotensive on an epi drip. It was quite difficult to ventilate. Here's his labs, and this is the result of transfusing a 12-kilo child according to an adult massive transfusion protocol. And you can see he's quite coagulopathic, thrombocytopenic. His TEG is markedly abnormal. And his hypotension, honestly, was due to his calcium deficiency. Once we corrected his calcium, we were able to get him off of the epidrip, and his blood pressure was quite normal. So a lot of derangements in the coagulation system combined with volume overload and ongoing coagulopathy. The trauma center saved his life, and this kid had a great outcome. He had no neurologic impairments at the time of discharge. He walked out of the hospital after a 3-month stay, which is a really long time for a kid who did not have a brain injury. So while our trauma system saved his life, there's a lot of opportunity for improvement here. His ICU course and ventilator course could have dramatically been decreased with appropriate balanced transfusion up front, with consideration of calcium, because if his calcium had been repleted, he probably wouldn't have got so much volume. And the subglottic stenosis from that very large ET tube that was placed required a couple trips to the operating room and probably contributed to his prolonged ventilator wean. So lots of opportunities for improvement all around the initial trauma resuscitation in this child. What happened in the operating room with, taking his spleen out, packing both upper quadrants, leaving him open, getting him transferred out to definitive care was all great. But the opportunities here for what we could have done better were really in the medical resuscitation, what happened in the emergency room and what happened with that massive transfusion protocol. So we'll talk about another case, and this is really polar opposite to that. So I think we've all seen these carnivals that set up in the mall parking lots. I'm not sure that I'll ever let my daughters ride on these rides, but I'm sure they'll do it anyway. We have a kid who was riding on the rave wave, which if anybody's ever seen this spins really, really, really fast with a lot of centrifugal force. Well, his safety bar failed, and he was launched off of this ride about 40 to 50 feet as a projectile, and he was launched straight into a light pole. Now, this mall parking lot was literally across the street from another trauma center, not the same one we talked about before, but so EMS scooped him up and drove him 2 blocks around the back of the adult trauma center and dropped him off in the ER there. Initially, he was tachycardic with a normal blood pressure, but quickly dropped to 67/45. He got a saline bolus and a push of epinephrine in the ambulance on the way to the ER. His GCS is 3. Obvious head trauma with a bleeding scalp laceration. This child was taken to an adult level 2 trauma center. And after the epinephrine, you can see he's even more tachycardic with a normal blood pressure now. He was intubated with an appropriate sized tube, and the bleeding scalp laceration was sutured. His initial hematocrit was 32. He had lots of rib fractures. His FAST was positive, and you can see he has a profound metabolic acidosis. Now, this particular adult level 2 trauma center is not a pediatric trauma center, but in Los Angeles County, they are approved, emergency department approved for pediatrics. So this particular emergency department has gone through and put a lot of effort and resources into being ready to take care of children and resuscitate children with emergent medical conditions. So this particular adult level 2 trauma center, while they are not a pediatric trauma center and did not provide definitive care to this center, they had early activation of air transport. So there's a protocol in place that as soon as it's recognized that a severely injured child shows up at this trauma center, they activate the transport system and they get the pediatric trauma center on the line. And they get them on the line before injuries are known. And they mobilize the air transport resources because they know that this kid is going out. They don't know what's wrong with him yet, but they know he's going out. So they immediately recognize that this child was in shock and that he had a severe TBI, and they activated their early transport protocol to get him out of their ER. And you'll see later that this kid was in and out of the ED with a lot done and on the aircraft in 55 minutes, which is pretty remarkable for a kid with this degree of injury. They have a pediatric massive transfusion protocol, and he got 2 adult units of Reds and 2 of FFP up front. He had hyperfibrinolysis on his thromboelastogram, so therefore got TXA. And in consultation with the trauma surgeon at the Pediatric Trauma Center, they decided to get a CT scan because he was responsive to those transfusions. And this did not delay his transfer. This CT was obtained while the aircraft was en route. He had shear injury and a subarachnoid hemorrhage on his head CT, and he had a grade 4 splenic laceration on his abdominal CT scan. His heart rate and blood pressure remained stable throughout the remainder of his course after the 2 of red cells and 2 of FFP. And he was transferred out, and again, wheels up under an hour from when the kid arrived in their ER. That's pretty remarkable when you're getting an aircraft on your pad, powering down, prep time, and getting back on the aircraft and taking off in 55 minutes. And this was not an accident. This is because this particular adult trauma center is prepared to take care of kids, resuscitate them, and transfer them out in a timely fashion to definitive care. Now, this child eventually, over the first 24 hours, did get a massive transfusion. You can see he got a lot of product. His spleen was salvaged. At 7, we really do try to preserve the spleen in these kids, and he never required craniotomy for his TBI. And he did go to peds rehab and had a good long-term outcome. So really an emblematic case of why peds readiness matters. And why this matters? Well, here's a map. And I think this really tells the story. Kids don't have access to pediatric trauma centers. They don't have timely access to pediatric trauma centers. Less than 20% of kids nationally are within 30 minutes by air or by ground. And we know that we can't always fly. So if you have to rely only on ground assets to transfer kids, less than 40% of kids live within 1 hour of a pediatric trauma center. So there's really a gap in access to care, to high quality initial resuscitative care, if you can't go to a pediatric trauma center. This is a different study that looks at the data a little bit differently, but the same story. If you look at the top map, this is pediatric trauma centers. Areas in white or the sort of grayish green have very low access to timely access to pediatric trauma centers. Areas in the green do a little bit better, but only 50 to 74.9% of kids who have access within 30 miles, okay? However, if you look at this bottom map, this is if you include all trauma centers, adult level 1s, level 2s, level 3s, and you include those as the initial entry points into the trauma system. We now can push this up to 88% of kids living within 30 miles of any high-level trauma center. And these trauma centers can really fill that gap for immediate access to care for children who need high-level resuscitation. So what is that high-level resuscitation? Well, I would argue that any trauma center should be able to provide this to a child, whether or not you normally take care of kids or not. Endotracheal intubation, establishing vascular access, giving blood, putting chest tubes in, TBI management, giving some Keppra, giving some 3%, maintaining normal perfusion, ventilation, oxygenation, temperature, glucose. This can be done anywhere. You don't need to be at a pediatric trauma center for this. But most importantly, doing all this and getting the kid out in a timely fashion to definitive care. So all of this can be done with appropriate levels of planning. And that's what we're here to talk about today, is how can we be ready to take care of children? And why are children so difficult to take care of? Well, it's because they don't all come in the same size and shape, and there's no cookie cutter dosing for these. It's different tube sizes, different drug sizes, weight-based dosing. Transfusing kids is very different, as I've illustrated. So having protocols for all of this stuff in a pre-existing fashion can really help, because when that child comes in having run over by a bus right outside your center or being launched off of the carnival ride right across the street from your center, you're not going to have time to put a protocol together. This stuff all has to be in your trauma bay at a fingertips access so that you can open the book, open the card, look at the card, and just get ready to roll. You have to be prepared to do this so that you can resuscitate these kids and save their lives. And there is now data that says that if your pediatric readiness is better, that mortality is better. This is a paper that was published last summer by Dr. Newgard, where they looked at 832 EDs, and they analyzed these data by the pediatric readiness score of the initial receiving hospital. So many of these kids did get transferred to definitive care, but if you look at the pediatric readiness score of the initial receiving hospital, this plot compares high pediatric readiness score EDs to the lowest, and you can see that there's a significant improvement in mortality for these kids. If a child was brought to a high pediatric readiness center up front, they had a 58% lower risk-adjusted mortality. So if we can improve pediatric readiness amongst all receiving trauma centers, we can save more lives for children. And the estimate of this paper is 126 lives per year could be saved if we can improve pediatric readiness amongst those centers that have low pediatric readiness scores. And the one thing that you can do to improve your pediatric readiness score the most is to get somebody identified as a pediatric emergency care coordinator at your center. And that's what we're here to talk about today. The other reason this is important is because this is a new standards announced by ACS. I suspect that's why many people are here today. Not only pediatric trauma centers, but all trauma centers are now going to be required to assess your pediatric readiness and have a plan to address any deficiencies. So again, we're not trying to make everybody into a pediatric trauma center, but that initial resuscitative care is really, really important. And the ACS has now recognized that and is now trying to push all trauma centers to be PEDS ready. So hopefully you get a lot out of today's webinar and next week, and we can help you become more PEDS ready at your individual center so that we can save more lives. And from that, I'll hand it over to Michelle and Lisa to introduce our next speaker.
Thank you, Erin. I appreciate it. So I want to give a quick introduction to our two nurse leads who will be taking you through the overview of each focus area today. We have Lisa Gray. She is our trauma domain and hospital domain co-leads for the EIC, as well as the assistant director of operations for the EIC. And Michelle Megling is our hospital domain co-lead, as well as works on our disaster domain. She's a coordinator for Rainbow Community Pediatric Emergency Services at University Hospital Rainbow Babies and Children's. And with that, I will let Michelle take it over, and we're going to dig into our first focus area, which is the